We're back, and today we are discussing how long should I be on hormone therapy during radiation therapy for my prostate cancer. As always, these are my disclosures, and the focus of today's discussion is coming from a recently published article from our group, and that is the optimal duration of androgen deprivation therapy with definitive radiotherapy for localized prostate cancer, out now in JAMA Oncology. From our prior presentations, you may remember the risk group stratification and the staging of prostate cancer that's listed in this figure, and there's a separate presentation on this if you learn more. And another way to break down the risk groups is shown in this figure. And in a prior presentation, I had this short section on the bottom about the duration of hormone therapy right here during the radiation therapy. So you see it goes from about 0 months, 4 to 6 months, maybe 12 to 18 months, and maybe about 2 years with this drug called abiraterone. And I want to break this down into a little bit more detail in this presentation. As you also may remember, there are various types of hormone therapy. And today, I want to focus on some of the more common drugs that are used for localized prostate cancer, specifically drugs like Lupron and Eligard. It's going to be the drugs that are used in the trials that we will discuss, and also the newest drug that's available that's called Orgovyx. This is oftentimes being used instead of these drugs, but I would say it's probably equally effective. So the discussion today applies to all these medications. And here is just another way of looking at the drugs. You saw this in our previous presentation. So we are focusing today on what is called androgen deprivation therapy. This is a type of hormone therapy, but in clinic, what you may hear patients say and what you may hear physicians say is either one of the terms. And so for the purposes of the discussion today, we'll kind of use them interchangeably, but there's really a lot of variations and there's technicalities in the terms. Okay, so the short answer to the question of the recommended duration of hormone therapy in months for various types of patients with prostate cancer, stratified by risk group. If you're treated with radiation therapy and if you have low risk prostate cancer, the optimal duration of hormone therapy is 0 months. You also probably should not be receiving treatment besides active surveillance. In other words, you should not receive surgery or radiation therapy. Once you get to favorable intermediate risk disease, you still the recommendation is 0 months. And then at unfavorable intermediate risk disease, we start to go up to 6 months. So the recommendation per the current guidelines is about 4 to 6 months. High risk disease, based on our analysis, the ideal number of months seems to be about 12 months, maybe going up to 18 months for some patients. For very high risk disease, maybe this is going up to 24 months, but maybe 12 months is still ideal. Maybe we need to add another drug that something like an abiraterone, and I'll show you this data in just a little bit. And then regional risk disease, not technically included in our analysis, but many of the patients actually still qualify because of something called stage migration. Right now, the national guidelines recommend 24 months, and I think that maybe this will actually decrease in the coming years. And this is for all the patients who are treated with radiation therapy after they are diagnosed with prostate cancer. What about if you're treated with surgery? So if you're going to have surgery for your prostate cancer, in the preoperative setting, that is before any surgery is done, you should not receive any hormone therapy. And if your PSA is rising after surgery, that is in the postoperative setting, you should really discuss with a radiation oncologist, because the question more is about radiation therapy, and then should you receive hormone therapy? And I would say that if hormones are used, the ideal number may be about 6 months, but this is actually very controversial. We will not talk about it in great detail in this discussion, and we'll save it for another video. And finally, for patients with metastatic prostate cancer, I think this is a debated duration. Historically, this has been years, but we're going to save this for another video as well. An overarching theme of this presentation is that the shortest duration possible of hormones is probably the best. And why do we say this? Well, hormones have toxicities. They have a lot of side effects. And so drugs like Lupron and Eligard are known to cause hot flashes, anemia, fatigue, a decrease in libido, impotence, a decrease in insulin sensitivity. So that means basically early diabetes, dyslipidemia, so bad cholesterol ratios, an increase in your BMI, so gaining fat mass, an increase in the risk of diabetes and heart disease, and also osteoporosis or weakening of the bones. Sometimes a drug like Casodex or bicalutamide is used in addition to these, and this can also cause liver toxicity, diarrhea, breast enlargement, and breast pain. And it also has, I would say that the shortest duration of being on Casodex is the best. And for many men with localized disease, you probably actually will not receive Casodex. You'll probably just receive Lupron and Eligard. I put these other drugs here. These are ARPIs, and you don't have to worry about these for localized disease when receiving radiation therapy, but just for juxtaposition, we'll list them here and some of their other toxicities. For men who go on hormones, this is just a year of being on hormones. You can see the differences in body habitus. So this is just identical twins after 1 year of hormone therapy. You can see the changes in the body and the weight gain, and so we know that the hormones are generally not good in terms of basically everything else. They help treat the prostate cancer, but they make a lot of things worse. So if we know that they make heart disease worse, is heart disease something that we have to worry about for men? And so the short answer is yes. And this is just an analysis of cardiovascular disease from our group. And here we are looking at some of the cancers where cardiovascular disease, this is death from heart disease, stroke, aneurysm, etc., and how those deaths compare. And you can see that for men who are diagnosed with prostate cancer, this is going all the way back to the 1970s through the 2010s. The majority of men now actually die of cardiovascular diseases instead of their prostate cancer. Now, this doesn't mean that you definitely shouldn't receive hormone therapy, but it does mean that this is a major competing cause of death for men with prostate cancer. And so any treatment that we're going to prescribe that will potentially increase the risk of that competing cause of death is something that we have to closely consider and we have to try to minimize and mitigate. What about heart disease in particular for prostate cancer? So this is another analysis from our group. You can see that in general, for all patients who are diagnosed with cancer, the longer that you follow the patients after their diagnosis, something like 10 plus years out, more and more patients will die of heart disease over time. And this is especially true for something like prostate cancer. So you can see that for the majority of men with prostate cancer at about 5 years, actually the plurality of them, and then the majority of them will die of heart disease, not from their prostate cancer. So the quote sometimes that men hear is that prostate cancer, many men will die with prostate cancer, but not of prostate cancer. And it's because of competing causes of death like this, like heart disease. So where does our analysis come into the picture? We performed this Dharma meta-analysis. This is from the MARCAP group, which you've heard about in prior presentations. And here we took several randomized controlled trials that were run across the world, mostly in the 1990s and 2000s and 2010s. And these trials were evaluating the ideal use of hormone therapy and the ideal duration of hormone therapy. The trials are listed here, and you can actually Google or look up their clinical trial numbers on clinicaltrials.gov if you want more details. Here's a quick snapshot of the trials and the patients who were included, the years of the accrual, the interventions that were used, and the treatments, the radiation therapy, and the number of patients that were on each trial. And just a couple of things that I want to bring to your attention here. So these patients, the risk group stratification and the T stage included, the PSA included, etc. This is all with the kind of like old school imaging, so CTs and bone scans. This patients are not receiving PSMA PET scans, which are kind of the standard of care today. With PSMA PETs, we actually have had stage migration. So that means that probably many of these patients had occult or hidden node positive disease, or possibly even metastatic disease. And with modern imaging like PSMA PET scans, they would have been upstaged, and so they actually would have been in a different risk category. The other thing you'll notice is that many of these trials, the hormones, we actually didn't know exactly when to give the hormone. Should we give it before the radiation therapy, and should we give it during radiation therapy? Should we give it after radiation therapy? For how long do we give it before? So all these questions were kind of unanswered. I would say the short answer today is that if you're getting radiation therapy, you should start hormones around the same time. So don't do hormones for like I don't know, 6 months, 12 months before, for the vast majority of patients. Okay, what did we find in this trial? So we found that ADT prolongation, or increasing the duration of hormones, improved multiple outcomes for men with high risk disease. And so here I'm plotting the hazard ratio. This is basically the risk of death compared to the control group, and that's on the y-axis. And then ADT duration is on the x-axis. So this is 0 months of ADT, this is 6 months of ADT, etc. They're going all the way out to 3 years. And so a hazard ratio of 1 means that your risk of biochemical recurrence, or the PSA going back up in the future compared to the control group, and that is compared to no hormones, is basically the same. But the lower the hazard ratio, the lower the relative risk. So once you get to about 0.5, your relative risk goes down by about half. Distant metastasis-free survival, so this is the chance of you developing cancer in other parts of the body, also goes down. You can see by about 18 months, we start to see this kind of plateau. And so it'll drop by about 20% with 18 months of hormones. Distant metastasis itself, so this is like developing a metastasis just as one kind of endpoint. So this also goes down. You can also see a plateau around 18 to 24 months. And then overall survival, this is death from any cause. You can see that this goes down and starts to plateau by about 12, 18 months for many patients. So I want to focus specifically on this overall survival plot and what this plot is showing you, because this is actually the most important thing for patients. Because the question is, do the hormones make you live longer? And we know that they're basically increasing your competing risk of death. It's kind of like you have 2 runners in a race, and unfortunately, the finish line is basically mortality. It's death. One of the runners is prostate cancer, and we want to try to slow that runner down. The other runner is every other cause of death: heart disease, stroke, aneurysm, etc. And the hormones are kind of making that runner faster. So what does this mean? Well, the hormones are basically accelerating the risk of other cause mortality. So that's plotted as OCM here. And so you can see that with the increased duration of hormone therapy, the increase in duration of androgen deprivation therapy, your risk of other cause mortality goes up over time. In contrast, your prostate cancer specific mortality, that is the chance of you dying specifically of prostate cancer, will go down with an increase in duration of the hormones. Because these 2 runners are kind of in the same race, there's a sweet spot of about 12 to 18 months for most high risk patients. And so probably remember from that slide where we were looking at the different trials experimenting with different durations of hormone therapy. Some of those trials use durations of like 36 months, and that is probably overkill because your risk of death from competing causes just goes up so much over that long duration. Let's break these data down a little bit more. And so, in this analysis, we had access to the risk groups and or at least some of the staging factors that were involved, and the trials. These are old school trials, so they didn't necessarily break down the risk factors as we know them today. But what if you had one intermediate risk factor, and how would that benefit the development of distant metastases? How would it reduce the uh, the development of metastatic disease? So we're going to plot two different uh, things here. We're going to plot the risk reduction. So this is kind of like the percent benefit, and then we're also going to plot the number needed to treat, or the NNT. So what this is trying to do, this red value, what it's trying to show you is kind of like an absolute benefit, and it's trying to tell you how many patients you actually need to treat with hormones for this duration of time to prevent the development of one metastasis. And so for one intermediate risk factor, and you can see that this is kind of like meant to show you favorable intermediate risk disease for whom we typically don't recommend hormone therapy for. The number needed to treat quickly goes up from like the 30s, 90s, and then hundreds plus. And so most physicians, if you ask them at what number needed to treat, would you start to not recommend intervention? It's a little bit variable. It depends on the actual intervention, but around 20, 30, 40, the higher that number is, the fewer and fewer physicians will recommend that patients receive treatment. So you can see that the risk reduction drops once you go from 0 to 6 months, 6 to 12 months, et cetera, and your number needed to treat goes up. And so this value is actually relatively similar to what we saw in this clinical trial called RTOG 0815. We discussed this in a separate video, and I won't get into it here, but the take home is that if you have favorable intermediate risk disease, and if you're thinking of hormones, it's probably overkill, especially hormone therapy prolongation. Well, what if you have two or more intermediate risk factors? And here we see that the number needed to treat actually goes down. So for unfavorable intermediate risk disease, this is kind of like a proxy of what we think unfavorable intermediate risk disease is. The current recommendation is that men get about 4 to 6 months of hormones. And you can see that there is still some benefit for a few patients going up to 12 months, but really going up above that is limited for the vast majority of men. So what we're seeing is that 6 months of hormones may actually be insufficient for some, and this is inspiring a clinical trial called NRG-GU10. And I'm going to show you that in just a little bit because we're trying to risk stratify, trying to find out who needs more hormones versus less. Okay, high-risk disease. So same thing. You can see that, yes, many men will benefit from 6 months and even up to 12 months of hormones. And then this benefit starts to drop once you get to like 12 to 18 months. The number needed to treat just starts to go through the roof. So once you get to like 2 years, 3 years, you're probably causing more harm than good. So the question from this is, does high risk need 18 months of hormones? And NRG GU009, which I'll show you in a second, is actually testing out 12 months of hormones. And it's also testing out another drug, which I'll show you, because we know that some of these men actually need more treatment. And finally, there is a subgroup of patients that's very high risk disease. And historically, in the NCCN guidelines and the staging manual, very high risk it did not have the same criteria as what we call stampede high risk. Now they are the same thing. So what we see here is that in the stampede high risk patients, 6 months or 12 months, probably not enough. We actually need some additional treatment, some additional drug. And so this is where we start to add abiraterone. and we start to think about something called complete androgen blockade, which you can learn about in the other video. Okay, so how do we better determine who should receive shorter versus longer duration of hormones? And what are some of the clinical trials that are being run in the US today? One of them, as we mentioned, is this trial called NRG-GU10. This is the guidance trial. So this is specifically for unfavorable intermediate risk prostate cancer. And you can't have prior hormones. You're checking something called the Decipher score. For more information about this, please check out our other video. And the Decipher is helping to guide the duration of hormones. So we know that the current recommendation is about 4 to 6 months of hormones. This is what uh, the middle arms, arm 2 and arm 3, are getting on this trial. But if your Decipher is low, you might actually get radiation alone, no hormones. You're treated like favorable intermediate risk disease with just radiation alone. In contrast, if your Decipher is high, you may get randomized to this drug called darolutamide that's added to the hormone therapy. And so we're intensifying the treatment. We're using complete androgen blockade with this other type of hormone. And next, what about for high-risk prostate cancer? So we're also checking the Decipher score. This is the genomic signature. And similar to what you saw with GU10, in this trial, the Decipher score will guide the use of hormone therapy, and it'll help with the randomization. So here, specifically arm 2, if your Decipher is less than 0.85 on the trial, you may be randomized to arm 2, which is kind of the middle ground duration. And this is, just from our analysis, we think this is probably enough for most men with high-risk prostate cancer. When this trial was designed, one of the standards of care was 24 months of hormones. So you can see that arm 1 and arm 3 are getting 24 months of hormones. And this technically is still within the realm of standard of care per the guidelines for high-risk disease. But from our MARCAP meta-analysis, arguably this may be too long because the risk of other cause mortality may actually supersede that risk of prostate cancer specific mortality by 18 plus months. Finally, on this trial, you have men who are getting they have a high Decipher, and they actually get 24 months of hormones. They actually get apalutamide and abiraterone. So this is also treatment intensification. They're getting complete androgen blockade. They're getting basically as many drugs as they can to slow down and shut down the testosterone axis so that the prostate cancer cells do not have any more fuel to grow. So if you have any questions, please reach out to me. And I hope that you found this video educational. I hope this will guide you in understanding how long you should receive hormones for and why some doctors may recommend a certain duration of hormones for the treatment of your prostate cancer.